Welcome to Broward Health's virtual chat series, Your Health, Our Priority. In this episode, we focus on cervical cancer awareness with Dr. Scott Jordan, a gynecologic oncologist at Broward Health. Welcome, Dr. Jordan.
Hi, thank you for having me.
Thank you for being here. We have such an important topic to discuss, cervical cancer awareness.
Yes, absolutely. Looking forward to talking about it.
Absolutely. So for our audience who may not know you, I am just going to introduce you by reading your brief bio. Dr. Scott E. Jordan is a gynecologic oncologist who also specializes in minimally invasive gynecology. He's been practicing medicine since 2012. After college and medical school at the University of Miami, he completed his residency training at Temple University Hospital in Philadelphia, Pennsylvania. He then completed an advanced pelvic surgery and minimally invasive gynecology fellowship at Fox Chase Cancer Center, also in Philadelphia, followed by a gynecologic oncology fellowship at Jackson Memorial Hospital and the University of Miami. He is board certified by the American Board of Obstetrics and Gynecology. Dr. Jordan's special interests include personalized treatment of ovarian, uterine, cervical, and other gynecologic cancers, robotic and laparoscopic minimally invasive surgery, cancer genetics, chemotherapy, immunotherapy, precision medicine, and cancer prevention and early detection. Wow, you have a series of different specialties, so I'm excited to hear what you have to say about the topic today.
Sure. So the last thing that you mentioned, the prevention of cancer, is really what we're going to focus on today, and specifically cervical cancer. So I don't know, are you able to see? Yeah, there are my slides. So cervical cancer is not the biggest gynecologic cancer in the United States. It's not the most common, but worldwide, in some parts of the world, it's the leading cause of cancer-related death among women in Africa and Central America. In the United States, a little under 14,000 new cases of cervical cancer are diagnosed annually. And worldwide, though, nearly 600,000 new cases per year, with over 300,000 deaths. So this is a big player in cancer worldwide. And the reason that it's not as big in the United States is because we do such a good job with prevention and early treatment. So a lot of patients, women, men alike, nobody, or I'm sorry, not nobody, but some patients don't understand everything that is included in the female reproductive anatomy. So this is just a little picture of the normal reproductive system in women. As you can see, at the top of the vagina, the cervix is sort of the entrance to the uterus itself, and this big muscular structure here is the uterus itself. This is the uterine lining, the endometrium, with the fallopian tubes and the ovaries off to the side. But what we're talking today is about this part that's just at the top of the vagina, that's the cervix. Cervical cancer progresses very slowly, and we'll talk about that a little bit more in a bit. As you can see it here on the left, this is what a normal cervix looks like, and this is what your gynecologist sees when he or she does a speculum exam. And this is what we look for. This is like a little donut-shaped muscular structure at the top of the vagina. This is what it looks like when it's normal. This is what we do a pap smear on. In early stage cervical cancer, you get a small changes in this lining, the kind of the skin of the cervix. And then as it spreads, this kind of takes over the whole cervix, begins to move up towards the body of the uterus, and eventually spreads out into the tissues that are next to the cervix and the uterus, and sometimes into the vagina as well. And that's when it becomes too advanced for surgery. So how do we treat cervical cancer? And I want to talk about what we do once cervical cancer has been diagnosed, to start out with, and then we'll kind of go back to prevention and what we can do to avoid these things. So the first thing that's done, and sort of the least invasive treatment strategy, and is also used as a diagnostic procedure, is a cone or a leap excision. And we'll talk a little bit more about what's entailed in this in a little bit, but this is a small biopsy just of that donut-shaped cervix that we're able to look at the cells, make sure everything that needed to be removed was removed, and it also allows us to determine, in a lot of cases, the stage of the cervical cancer. In early stage cervical cancer, a simple or total hysterectomy can be performed as a curative procedure, and that can be done with a traditional like a bikini cut incision, or it can be done with laparoscopy or even with the robot. Once the cancer becomes visible and really becomes larger than 0.5 centimeter, so we're really still talking about a very small cancer, a radical hysterectomy is required. And what that entails is removing not just the uterus and cervix and fallopian tubes, but also a little bit of the vagina and some of those tissues that are next to the cervix and the uterus. That's called the parametria. And so the actual, what we actually remove isn't that much bigger, but this is a much more invasive surgery, and it requires an open incision. It should not be done with the robot or with laparoscopy with small incisions. We generally have to do this through a bikini cut incision. This can be done for cancers up to about 4 centimeters, as long as the cancer hasn't spread outside the cervix. Unfortunately, once it gets beyond the cervix and starts to go into that tissue next to the cervix and the uterus, that parametrial tissue, we're really stuck with options that are not surgical. We're still able to cure the cancer, but we have to do radiation instead of surgery, and that's typically about a 6-week process, doing radiation with chemotherapy at the same time. These are the locally advanced cancers, and sometimes with spreads in nearby lymph nodes. Once cervical cancer recurs, or if at the time of diagnosis there is distant spread, this would be a stage 4 cervical cancer, then we're stuck treating systemically. And a lot of times at this point, this is an incurable cancer. So that includes chemotherapy and sometimes immunotherapy. But these are really suboptimal treatment options compared to radiation or surgery, because once we reach this point, the cat's kind of gotten out of the bag, and we oftentimes cannot cure cervical cancer when it's advanced stage and distant spread like this. So all these different treatment options, there's sort of no such thing as a free lunch. So we have all these treatment options. We are able to cure a lot of cervical cancer, but once it's been diagnosed and we have to treat it, there are sequelae and complications that can happen in treatment. And I want to be clear that this doesn't happen always with the treatment, but these are possibilities of side effects and complications of treatment with surgery, or some of these go with the chemotherapy, some of these go with the radiation, but there are possibly development of incontinence, fistula, which is a connection between two structures that shouldn't be connected. So a vesicovaginal fistula is a connection between the bladder and the vagina. A rectovaginal fistula is a connection between the rectum and the vagina. Vaginal stenosis is a complication of radiation. These treatments can cause long-term pelvic pain that kind of goes along with the vaginal stenosis, which is a narrowing of the vagina. In women who are of childbearing age, when they undergo treatment for cervical cancer, a lot of these treatments cause infertility. They cause early menopause. And of course, the cancer can recur, requiring additional treatment. Radiation and chemotherapy can cause chronic anemia. The treatments themselves can cause another cancer to form if given enough time. 20, 30 years down the road. Radiation can also cause pain and also chronic diarrhea, and that's something that has to be managed like for the rest of your life. And I bring these up not to be a huge downer and scary about everything that we can offer, because really we do a great job at treating cervical cancer, especially when it's diagnosed in the early stages. But I want to stress that prevention is so much better than treatment, because a lot of times we can prevent these things before they even start by doing good screening, catching pre-malignant lesions with pap smears and HPV testing. And we can even prevent HPV vaccine, as Dr. Sobel talked about in his talk, with a 97% efficacy in prevention of HPV vaccine infections that can cause the malignant transformation of these cells. So what is this connection between HPV and cervical cancer? So HPV is human papillomavirus, and it's important to know that it's not that some women have HPV and they're the ones that have caught this horrible STD. HPV is so prevalent in the population that basically if you have an HPV infection, it essentially means that you're sexually active or have been sexually active at some point. It's completely asymptomatic in men and women. And so there's really no signs of HPV infection other than this progression towards malignancy. And so this is pretty much the simplest drawing of this that I could find. And I apologize that it's still so complex, but basically the HPV infection gets into these normal cervical cells. It causes transformation of these cells into this pre-malignant, precancerous lesion. And this takes a long time. Like I said, this takes months to years to progress from just a simple HPV infection all the way to a dangerous pre-malignant or precancerous lesion. And these CIN denotations here are cervical intraepithelial neoplasia. And basically what that means is that is a cancerous, those are cancerous cells that haven't actually invaded into the cervix and actually become cancerous yet. So at this point, if we can remove a CIN 2 to 3 lesion, then we can prevent it from eventually becoming a cancerous lesion. So that's the idea of pap smears, is that we catch in this time what the HPV has caused, and we prevent it from becoming an invasive carcinoma. So this progression takes time, but at the same time that it can be progressing, there's also the body's immune system, which is fighting off this HPV infection. And while that happens, sometimes infection that becomes CIN1 or CIN2 can actually regress back to normal. And that can take months to years as well. So that's also a possibility. Once it's not a sure thing that once somebody has an HPV infection or somebody has CIN2, that it will definitely progress to an invasive cancer. In fact, most HPV infections are cleared by the body without any progression to cancer. So many of my patients don't understand exactly what it is that we're doing when we're doing a pap smear. You can't see what your gynecologist is actually doing during a pelvic exam. So I think this is a great picture to represent actually what we're sampling. And we take a little brush, we visualize the cervix, and we take a sample of those cells that have this possibility of becoming becoming cancerous, and then we send those to the lab, and those are tested for HPV infection, as well as the cells themselves are looked at by a cytologist or a pathologist who is able to say if they look abnormal, if they look concerning for cancer. So if only the cells are looked at, we recommend that a pap smear is done every 3 years, starting at age 21. If HPV is also screened for it. In other words, looking for the virus that causes these cells to be abnormal. Because of that long timeline that we talked about on this screen, the HPV screening only needs to be done every 5 years, because in the meantime, many of these HPV infections will actually be cleared by the body and will never even progress. So it's such a long timeline and with so many different possibilities of regression that we don't need to be screening any more often than 3 to 5 years. And screening continues up to age 65 if 2 prior negative tests are present in the medical record. So what are the harms of screening too often? I'm sure many patients remember that we used to do this every year. Why don't we do that anymore? Well, for one thing, getting a pap smear is not comfortable. And there's a lot of anxiety for a positive test result of a pap smear, which we then bring you in for additional testing, which may have resolved spontaneously on its own anyway without us even intervening. There are also sometimes false positive results, which can also cause anxiety and might cause us to overtreat and perform treatment that's not necessary, again, when these things can resolve spontaneously, cause additional discomfort, pain, maybe additional procedures that have risks. So risks of this treatment are most pronounced on pregnancy outcomes. And a lot of times these are in young women, 20s to 30s, who still have plans of becoming pregnant. So risks of this additional treatment for abnormal pap smears includes increased risk of second trimester pregnancy loss, preterm rupture of membranes, and preterm delivery. So this is not a benign thing to do. And what am I talking about when I talk about this procedure that we do, this cone biopsy or LEAP procedure that we do to further work up an abnormal pap smear? And that's either a cone or a LEAP procedure. We call it a LEAP because it stands for loop electrosurgical excision procedure, which is basically a hot electrified loop, which we use to amputate a small donut of cervical tissue or a cone of cervical tissue to get those high-risk areas out where the abnormal pap smear came from. So that's removed, sent to the lab, and processed. And we make sure that, one, there's not cancer there. If there is cancer there, then it may need to be worked up further. If there's not cancer there, we also make sure that all of the abnormal cells, all of those precancerous cells, were removed in this specimen. But as the cervix functions in the body, its main function is to hold in a pregnancy that is normally in this area of the uterus. Because that's its function, removing part of that cervix, you can imagine, has the potential to have effects on pregnancy. So we really don't want to be doing this procedure unless it's really indicated. And so decreasing the amount of pap smears that we're doing from 1 to 3 years isn't a kind of a cost-conscious thing or because your doctor's lazy. It's really because we don't want to get positive results that we have to act on in cases where it would actually do more harm than good. So again, prevention. What can we do to prevent these abnormal pap smears, to prevent having to do these procedures, and worst of all, getting diagnosed with cervical cancer? The biggest thing that we can do is get an HPV vaccination. It's recommended for men and women, so men can do this too and prevent spread of HPV up to age 45, starting at age 9. So your daughters and sons should be vaccinated by their pediatricians. If you have not been vaccinated and you're under age 45, ask your healthcare provider about getting an HPV vaccine. That can even if you're already sexually active or well into your 30s, it's still helpful up to age 45. Smoking, we didn't talk a lot about yet, but smoking not only increases your chance of other cancers, but it actually hurts the immune system, the ability of the body to clear HPV in the cervix. So it increases the chance of progression to those precancerous and cancerous lesions. And then minimizing the amount of immunocompromise. So patients with HIV, patients who are transplant recipients who have to have immunocompromise for medical reasons, are at a higher risk of progression from HPV infection to cancer. So we watch those patients a little bit closely, but HIV patients, which we certainly have a lot of HIV patients that we see in our practice and are here in South Florida, can stay current on their heart meds to prevent the viral load from getting out of control and preventing worse immunocompromise. And then finally, staying current on screening. Make sure you're getting your pap smear and seeing a gynecologist regularly. It's important to note a pelvic exam and a pap smear are not the same thing. So you need to see a gynecologist every year for a screening and a pelvic exam. But your gynecologist will talk with you about when pap smears are indicated and make sure you're up to date on those. So just in closing, I wanted to thank the Mosaic Group for putting this talk on, inviting me to talk. The Community Health Services, Broward Health Physician Group is my employer, Broward Health Medical Center, which is where I work. Really grateful to get to talk to everyone. And I think with that, Anne-Marie has some frequently asked questions.
Yes, I do. So, Dr. Jordan, man, this was very enlightening. So, thank you for sharing this information. I actually learned some new information, and I think when the HPV vaccine was promoted many years ago, it was initially said for ages 9 to 26 or something like that. Am I correct?
So many times that I don't remember what all of the changes are, but the most current recommendations are all the way up to 45.
Right. So I don't think that, so I'm glad you mentioned that, because I don't think a lot of people know that the age limit has been extended up to 45. So I'm really glad that you pointed that out, so that people who are in their later 20s, 30s, and even early 40s know that they can still get this vaccine.
I mean, just to kind of get on my own soapbox about the vaccine, I know Dr. Sobel talked about it, but with all of those, while we can often cure cervical cancer, we can't always cure cervical cancer. And often when we do, the cure has a lot of side effects and has a lot of downstream effects and is life altering. And so prevention, in a case where we can prevent awful cancer, I implore every patient and everyone with daughters and sons also to get this vaccine so that we can really decrease the number of patients that we're seeing with this awful disease.
How can we talk to more men? I think a lot of times, women are definitely getting the information. Statistics show that men go to the doctor less. So how do we engage more men on the preventative measures as well as the vaccine? And I know Dr. Sobel touched on it a little bit, but from your perspective.
Well, I mean, my perspective is a little bit skewed because I only see women, and I often only see women with either advanced precancer or various stages of cancer. So I kind of see the far end of that spectrum, but I think encouraging women who are listening to this talk to get their sons vaccinated, talk to their pediatricians about it, and then encouraging pediatricians in the community to really take ownership of this, because the gynecologists and the ENTs, we're not. There's not much of a debate amongst us that everybody should be vaccinated, but the pediatricians don't treat cervical cancer, and so they don't see it. This happens in the third to fourth decade of life, and so it's important for us to implore our pediatrics colleagues to really have this discussion with both their male and female patients.
Absolutely. Now, when you talk about if someone receives a abnormal PAP, and you said the body kind of corrects itself oftentimes, and I know you mentioned not smoking. Is there anything related to diet or exercise in helping the body kind of rid itself of, HPV if you do incur, in fact, come in contact?
Sure. I mean, for all of the cancers I treat, having a good diet, exercising, not being overweight is always going to be helpful, no matter what the circumstances. Specifically for clearing HPV, I don't know that it benefits. It has any benefit there, but certainly just being in good health and having a good functioning, fully functioning immune system. Those are basic ingredients of that diet and exercise, and that's sort of the easy thing that each of us can do every day to make sure that we're in as good of health as we can be.
Absolutely. A lot of our health comes down to diet and exercise. So what about, I know you talked about some of the treatments. What have you seen have been the most effective that cost the least, not cost from a monetary, but causes the least amount of damage if early detected?
That's the magic words is early detection, because we're able to do less invasive surgeries. We're able to do minimally invasive hysterectomies. We're able to sometimes treat these with that cone excision procedure alone without even doing a hysterectomy. When this is caught early. Once you get into the radical hysterectomy or radiation, that's when you start seeing more and more side effects and more invasive treatments. It's not to say that the treatments are extraordinarily difficult or impossible, but certainly there's a big difference between an outpatient cone excision procedure and 6 weeks of chemoradiation. So early detection and getting screened regularly is definitely the most important thing that we can do with respect to minimizing those big treatments that we do.
Right. Now and I'm sure you have your work cut out, especially with educating. So again, thank you for doing this presentation, but with educating women about cervical cancer, especially when it may be taboo in their culture, they may have different religious views, or just may not understand or know enough about their bodies, like even with your opening presentation of the female reproductive organ. Or system, for those who may not have been very comfortable with their bodies, explore their bodies, take as much care of their bodies, or it's just norms within their culture and religion. How have you been able to really effectively educate those women?
I think that's a very good question, and it's a really difficult question to answer. I have, in talking to family members, truly, family members, like people that are related to a Gynecologic Oncologist, and members of my church about vaccines, even who are uncertain about taking a vaccine. My biggest deterrent and encouragement for a vaccine comes down to what I've seen in my patients. And cervical cancer is an awful, awful disease. Thankfully, we don't see a lot of advanced cervical cancer. We don't see a lot of women dying from cervical cancer in the United States, but it does happen. And when it does, it really makes a huge impact even on me as somebody who does this for a living. I had a teacher in Philadelphia at Fox Chase Cancer Center who used to say that cervical cancer was the worst gynecologic cancer because it robs women of their dignity. And what I mean by that is oftentimes cervical cancer patients end up, by the time it's advanced and they're to the point where they're going to be dying of cervical cancer, and thankfully this doesn't happen as often as in other disease sites that we have, but if it does, these are women who may have blockage of their urinary system, may have to have their urine draining out through tubes placed directly into their kidneys. They may have be completely incontinent of urine from fistula to the vagina from the bladder. They may be incontinent of stool from fistula from the rectum to the vagina. And these are women who have very, very little quality of life as a result of this. And I wouldn't want that for anybody. And I think that's, maybe it's just because that's the perspective I take as an oncologist, is not wanting what so many of my amazing patients have had to go through for anybody. But I mean, I'd do anything to make sure that as many patients are getting vaccinated and screened appropriately as possible, just to prevent that.
Absolutely. So for those who may be single and dating, and because this is not one of the ones that are talked about, like HIV, where you can, go get a HIV test before you become sexually active with a new partner or someone that you're dating. How is there a way, for a woman to tell that person, can you get checked for HPV?
No, it's really not. The only screening that we do is that test, every 5 years as part of cervical cancer screening, and there's no symptoms for HPV. But like I said, the majority of the population, I mean, you should just assume that you either have or have had HPV at some point, because the majority of the population has been infected at some point and most likely has cleared it. Remember, most people that get HPV clear it on their own. There's never any progression. But in those that do, and the odds are that you'll end up with it at some point, it's important that we're screening and making sure that we're dealing with any downstream effects of it. So it's not like getting a clean bill of health for like chlamydia, gonorrhea, HIV, syphilis, things like that. It's a little bit different because it's a virus that very, very, very slowly causes cancer, and we can prevent the virus. We can a lot of times catch and prevent the cancer, but we can't treat itself.
Okay, so basically there's no test for men either. So I know women can get a pap smear, but is there anything for men?
No, I mean, not that I'm aware of. The conversion rate in men from HPV to like a penile cancer is very, very, very low. So it's not screened for in men in the same way. And Dr. Sobel can talk more from a head and neck perspective. But from just a genitourinary perspective, men do not have the same risk for penile cancer as women do of cervical cancer. So the screening is focused on women.
Okay, and I have a couple more questions. So since there's like really no way for men to be checked or detected, is there a way for a woman to protect herself from potentially, like you said, I know more than likely you said most of us would probably get it anyways, but is there any way to protect against it?
So I guess I should say that most of us would get exposed to it. But there's a great way to get protected. A vaccine. We have a vaccine that protects, and there are dozens of kinds of HPV, but we have a vaccine that protects against the 9 most common types. And it's a no-brainer. I mean, it's three injections, 2 injections if you're under 15, I believe, and actually prevent getting the HPV infection.
Okay. And then if they didn't get the vaccine, but they did get the HPV virus once in their life and it went away, would they get it again?
So because there are so many strains of HPV, there's definitely a possibility of getting it again with a new partner. Generally, we see that women who are in monogamous relationships, and of course, we never say in gynecology, we never really consider a monogamous relationship because the woman can only control what she herself has done. But women in true monogamous relationships, they're not getting reinfected with HPV. They're getting the one, maybe clearing it, and then that's it. And that's why we stop screening at age 65 if you've had 2 prior negative tests. If you've got a new partner at some point later in life, you might not end up having negative tests. That you may develop a new strain of HPV, and that's okay. That's fine. We deal with it at the time, and there's no. I want to stress that there's no stigma to HPV infection. Really, most of the population has it. But I mean, it is possible to get multiple HPV infections because there are so many strains.
Wow. Now, how does someone find out about your services, Dr. Jordan, and how do they reach out to Broward Health if they need a screening, if they need a pap smear, they may not have a gynecologist, what should they do?
Sure. So Broward Health, they have a few gynecology practices that practice out of here. So you can call the main Broward Health number at 954-355-4400 and ask for gynecology services. Also through the community health services and all of the primary care offices that are sort of sponsoring this talk. Primary care, many primary care doctors, family medicine doctors do pap screening. And a lot of times those results then get referred to a gynecologist or sometimes even a gynecologic oncologist like myself. And we know somebody who has a new diagnosis of cervical cancer or is being told that they need surgery for maybe a pre-malignant or a precancerous lesion, or if you have questions about cervical cancer, either a new diagnosis or want a second opinion about a recurrent cervical cancer. My office is, the number's coming across the bottom of the screen there. It's 954-355-4345. And I'm here, and my partner, Dr. Slomovitz, who's actually kind of a world expert in cervical cancer. We are more than happy to see anybody and talk about treatment options and how we can best serve you and your family members.
Awesome. Well, thank you so much. This has been very informative, and we hope that everyone who views this video will share it with other people in our community. This information is just great information, and we want to make sure that everyone is informed and that we all take the preventative measures necessary to prevent cervical cancer. So thank you again, Dr. Scott Jordan. Thank you for tuning in, everyone. And this is Broward Health's virtual chat series, Your Health, Our Priority.
For more than 80 years, Broward Health has provided compassionate care to our community, growing to be one of the 10 largest public health systems in the United States, with convenient locations throughout Broward County. Broward Health has urgent care centers for minor health concerns, primary care providers and specialists across multiple disciplines, outpatient centers for quick access to diagnostic services and treatments, the Sala Foundation Children's Hospital for advanced family-centered pediatric care, and acute care hospitals with dedicated trauma centers. Broward Health seamlessly provides a complete continuum of care at every point of your healthcare journey. Our services cover the entire health spectrum, including bariatrics, cancer services, emergency services, heart care, neonatal care, neurology, orthopedics, pediatrics, senior care, transplant, and women's and maternity services. As the first provider of open heart surgery in Broward County, Broward Health continues our tradition of innovation through advanced, minimally invasive robotic surgery and investments in clinical research and academic medicine programs. Our outreach programs, such as preventative health screenings and wellness education, can help prevent chronic diseases, promote healthy lifestyles, and improve the health outcomes of everyone in our community. Broward Health, where award-winning care and clinical excellence are all close to home. Broward Health, a passion for caring.